Thank you so much for the invitation to speak. I'm really pleased to have this opportunity to tell you a little bit about how I would see ELF incorporated in clinical practice, current and future applications. These are my disclosures. And I will start by framing the issues of liver disease currently, and as they compare to maybe eras that were earlier in the 1988 and 1994, and as we move to the right here of this graph to 2021. These are studies from NHANES, which is essentially an evaluation of the general population in the United States. And as you can see here, when we split the chronic liver disease by etiologies, MASLD has been the predominant etiology from even way back when, but its prevalence has increased considerably from approximately 20% in the earlier years to up to 38% based on the most recent estimations. And this is in accordance to the known increase in obesity from 22% to about 39%. So when we talk about chronic liver disease, we really talk about mostly MASLD. Alcohol-related liver disease is also one of the increasing prevalences in the United States and the Western world in general. MASLD and MASH are a current and growing crisis in the United States. And just for an update, MASLD is what we formerly called NAFLD, or non-alcoholic fatty liver disease, and MASH is what we formerly called NASH. So just for everybody's recollection of these new terms. So going back into the MASLD and MASH space, it affects approximately 80 to 100 million people in the United States. In about 20% of those who have excess hepatic fat, there's a more aggressive phenotype called MASH, which is essentially the liver's response to that excess fat by inflammation, which essentially drives fibrosis with time. And that's the population that tends to progress to cirrhosis if left untreated. Cirrhosis, as you know, is associated with several complications, from liver cancer to decompensation events that are treated with liver transplantation if it gets to that stage. So when in clinic we diagnose people who have MASH, the goal is to prevent that progression. How can we identify them earlier and interact earlier with them with the disease pathophysiology to not get to cirrhosis stage? There are several factors that are also important that contribute to this progression and to these complications. Diabetes is a very important one, so that people with diabetes in addition to obesity are kind of top of the line in terms of fast interventions. But the other metabolic comorbidities that are important are dyslipidemia and hypertension. People do progress to cirrhosis, and unfortunately MASH has become at the top of the indications for liver transplantation. It is the second most common overall, but first indication for transplantation in women. So a very important issue. We struggle with this in clinic in our daily practice. We're going to zoom into the fibrosis story. I mentioned a little bit that the main focus is to decrease the chance of progression to cirrhosis. So the first question we have in clinic is, does this patient have fibrosis anytime we deal with MASLD or MASH? And fibrosis is measured in 4 stages, as you may recall, 4 being cirrhosis. The clinically significant fibrosis starts here at stage 2, and you can see here why. That is because the mortality rate increases starting at this stage, and then it's exponentially higher as they move towards stage 3 or 4. So clinically significant fibrosis for the remainder of this talk means stage 2 and higher. The clinical trials with investigational agents have also focused on this fibrotic MASH at stage 2 or higher range. So that's really where the bar is in clinical practice. We want to identify people here at stage 2 so we can intervene so they don't progress to stage 4. Why is it important? One is because we have a baseline understanding of the liver disease severity, and that's important in management in all liver diseases. And hepatitis, in viral hepatitis, is for treatment duration or treatment initiation. In MASH is for treatment initiation. As I mentioned, stage 2 or higher is that clinically significant fibrosis where people may become candidates for therapies that have been approved for MASH, which we will discuss a bit later. It's also important because if we diagnose people with advanced fibrosis, so stage 3 to 4, it's the time to implement liver cancer surveillance and esophageal variceal cell screening in any etiology of liver disease. It's also important for prognosis, for mortality, and for decompensation. As you saw on the previous graph, that mortality risk increases with the stage of fibrosis. It's also important when we monitor people. So for the longitudinal monitoring of liver disease, we use fibrosis parameters to assess either progression of disease or regression after initiation of therapy or weight loss in those with MASH. So it's very important. It's really the number one parameter in clinical hepatology. MASH remains undiagnosed mainly because there are several reasons, and you might have remembered the slide from a previous presentation, but essentially there are knowledge gaps in screening and diagnosing. So a lot of these people remain undiagnosed in clinical practice. We see a lot of scenarios where incidental hepatic steatosis is found on an imaging performed for another reason, but it's not really acted on. So patients may not be aware that this was found because their provider hasn't mentioned it, or they were reassured that it's just fat, it's common, nothing really to do at this time. And unfortunately, the disease can progress over time to cirrhosis. There are also diagnostic and screening challenges. I describe hepatology as a puzzle. Every piece has to be to line up and has to be evaluated. So it's a combination of medical history, physical exam, blood test, paying attention to those platelets, to those liver enzymes, and then imaging to be done at the right time. A lot of times some pieces of the puzzle are missed and then the whole picture is missed. Patients don't have symptoms. The disease progresses silently. Some have a little bit of discomfort in the right upper quadrant, but it's not universal until late in the compensation stage. And also before this recent approval of liver-directed therapies, there was a little bit of lack of impetus as to why should we screen because there's no treatment for it. People had a hard time losing weight before the weight loss medications were implemented in common clinical practice. So historically, we had limited treatment options, and that fortunately has changed in the last couple of years. But overall, there's really an unfortunate reality that we don't implement these measures of fibrosis estimation often enough in clinical practice to find this early in stage 2 at least. In 2024, as you're all aware, we had the first FDA approval of a MASH-specific drug, which was resmetirom, based on this phase 3 trial published in the New England Journal of Medicine. It showed improvement of fibrosis and MASH resolution with this medication. And this was a major pivotal point in the field because it wasn't just a therapy, but it was a leap forward in the way we approach mast cell disease continuum. It increased that impetus of case finding in non-hepatology setting. This why bother was no longer a reasonable question because now we have treatments and we want to identify those patients. There was motivation to risk stratify. So if there is incidental steatosis on imaging, then there was a need to ask the question, is there fibrosis along with that, which cannot be seen in typical imaging modalities such as ultrasound or CT scan. So something else needed to be done because the patient may be a candidate for treatment. And also, the important piece of that was that there was no biopsy needed. So the world kind of moved towards non-invasive testing away from a need of biopsy and really it just kind of increased the opportunity for case finding. So how do we case find? How do we risk stratify? The gold standard had been historically a liver biopsy, but over the last decade plus, we've really in clinical practice moved away from it. It's still used in clinical trials, but there's also a move there to maybe move towards more non-invasive testing and assessment of drug efficacy. We don't use biopsy because of pain, bleeding, infection. That's all the potential complications. So it's not as easily accepted by patients. We rarely use it in clinical practice now. Maybe when the clinical picture doesn't match, maybe there's a different etiology than MASH. Something like autoimmune liver disease, for example, still needs a biopsy for confirmation. But those are rare situations. So what we use currently is mainly elastography or imaging methods, which are available in specialty offices in gastroenterology and hepatology, but also are available for open use for non-hepatology spaces too. So primary care physicians, for example, have access to a FibroScan or MR elastography. We also use blood-based biomarkers, which I'll talk a little bit further down this conversation. Those are obviously easier access to anyone, not necessarily tied to a specialty clinic. And those are essentially FIB4 and ELF, which will be the main point of discussion for later today. So enhanced liver fibrosis test or ELF test is, as you know, a proprietary test with 3 components, which are listed here on the left side of this slide. This is one of the earliest studies that have shown some guidance into what cutoffs should we use and should we pay attention to in clinical practice. This study was a meta-analysis which had an outcome of advanced fibrosis, and advanced fibrosis by those histologic stages would be stage 3 or higher. So these cutoffs were developed with that outcome in mind. We told that we have since moved the bar a little bit lower to stage 2 or clinically significant fibrosis, just because now we have those therapies for that earlier stage. So take that into consideration as you analyze this slide. But for advanced fibrosis, the AUC in this meta-analysis was 0.83, which is really good. The cutoffs developed there were 7.7 is a lower cutoff, below which we could exclude advanced fibrosis with a 85% sensitivity, so about 15% of those of patients with advanced fibrosis or cirrhosis would have been missed. A second cutoff of 9.8 was used for specificity, so increasing the specificity that what we call advanced fibrosis is truly advanced fibrosis in about 90% of cases, so we would normally diagnose about 10% of patients. And then 11.3 was a cutoff that was associated with a higher risk of decompensation. So we're pretty convinced that anyone with a alpha 11.3 or higher is likely to have cirrhosis because they're more likely to have decompensating events. There's a moderate risk here, a gray zone between these two cutoffs where we really didn't really know what to do about it. So the field, as the initial studies were permeated, had a need for kind of figuring out what to do with this gray zone. So the cutoffs have evolved in terms of research since then, and they're continuing to evolve. There are other studies that I want to show that support the same kind of performance metrics also for advanced fibrosis, so stage 2 or higher. AUCs of 0.81 when compared to biopsy, 0.79 when compared to FibroScan with this liver stiffness threshold of 9.6 kilopascals. So again, that cutoff of 9.8, in addition to a high FIB4, had a pretty good specificity for advanced fibrosis. A more recent study using the NIMBLE cohort of FNIH, a large consortium of biomarker studies, showed more specific cutoffs for stage 2, 3, and 4. So if we're focusing now to stage 2, which I said in clinical practice is the one that we're really wanting to pay attention to, in this situation and in this study here, if you focused on the graph here on the left, A cutoff of approximately 9.2 is what optimized both sensitivity and specificity for stage 2 fibrosis. So it depends on what we want. If you want a high sensitivity, we want to lower that cutoff, or we want to balance it. It's somewhere in the middle. Somewhere in the middle is where the field is leaning towards. So 9.2 would have been the study that supported that new cutoff as we learned more about ELF in clinical applications. So that's what we're using at Mayo Clinic with this new available test. And you can see here a report that is just the standard report for interpretation would be a score of 9.2 or higher is suggestive of a high risk of fibrosis stage 2 or greater. And that 11.3 cutoff or higher would be suggestive of cirrhosis with a higher risk of liver-related events. So you'd see here with a report of 6.8, it will put it in the normal range. And a score of 10.09 or higher would put this into higher risk for stage 2 or higher fibrosis. I want to emphasize something that I haven't mentioned at the beginning. Currently, the ELF test is FDA approved for prognosis. So its ability to estimate a risk of development of decompensation or liver-related events. The diagnostic piece of it, I think, is under works now with the FDA. So that's kind of the data on ELF, and I wanted to show you mainly not for its performance, which I'm sure you are aware of, but for the idea of this cutoff movement and how we learn and how it evolves over time, and how we can make use of it in clinical practice now, and what's potentially to be further refined in the future. So the current pathways that are available in the CITL guidelines as of 2026 are still using kind of that initial threshold of 7.7 that was initially related to that study from earlier, that meta-analysis that I showed you initially. But this is what the AASLD practice guidance shows currently or recommends currently. There's a clinical suspicion for fatty liver disease. This is prior to the nomenclature change, so replace that with steatotic liver disease nowadays. In primary care or non-GI or hepatology care, the first line of testing to exclude fibrosis or to evaluate for fibrosis is a FIB4, and that's because of its convenience and ease of use. As you recall, FIB4 is calculated using age, AST, ALT, and platelets, so something that is available in the routine medical evaluation in primary care space. If patients are having a FIB4 lower than 1.3, then they are at low risk of advanced fibrosis. FIB4 was developed for advanced fibrosis, so stage 3 to 4. Again, that bar is not to develop to identify stage 2. So if they are below 1.3, they're at low risk of having advanced fibrosis. So this needs to just be reassessed periodically every 1 to 2 years if they have persistent metabolic risk factors such as diabetes, obesity, and hypertension and dyslipidemia, which are part of the metabolic syndrome. If they don't have diabetes or they have less than 2 risk factors, then they should be reassessed every 2 to 3 years of the FIB4. If it's above 1.3, then we need to do something. And that something could be either a direct referral to hepatology if the score is 2.67 or higher, or if there's a possibility, and we prefer that just to further fine-tune this FIB4, which is not very specific at this cutoff, would be a secondary risk assessment with either VCTE, which is short for FibroScan or vibration-controlled transient elastography, or ELF if FibroScan is not available. It depends on the health system's resources. And these are the cutoffs recommended here. As you remember that 7.7 cutoff on that initial slide, if it's below that, we can be pretty sure that the risk is low of advanced fibrosis. And also for VCTE, that cutoff is 8. If it's between the gray zone of 7.7 to 9.8, we say in the intermediate risk, but we're not quite sure what that means because a lot of patients can be just higher ELF, but not having advanced fibrosis, as you saw from the more recent studies that you saw. So ideally, we would on a score of 7.7, which would be too low, we would have something like a FibroScan for confirmation before sending to hepatology. That's kind of my interpretation of these guidelines based on this recent data that I showed you. If the score is more than 9.8, I think a referral without a FibroScan makes sense. So once they get to us in hepatology, we may do other things like MR elastography to confirm, very rarely biopsies if there are discordant tests, or sometimes if we have two tests that are agreeable and are interpretable in the right context, then we just take them to face value and we don't need to repeat anything else. But essentially, that's a bit less of a structured approach because we take it based on the individual's risk and how those pieces of the puzzle kind of come together. If an ELF has a value of higher than 11.3, that's pretty consistent with a high or supportive of a diagnosis of cirrhosis, and then we will consider the longitudinal monitoring and surveillance for those complications that I mentioned earlier. So that's what the current guidance suggests based on the AASLD recommendations, and that's where ELF is going to be playing a role. What we do at Mayo, putting these data together and the recommendations from the guidance, but also taking into consideration the updated literature, we followed a kind of an altered pathway. If we suspect mast cell, either by incidental steatosis or abnormal liver enzymes, we recommend for our primary care colleagues to do the same thing, assessing the likelihood of advanced fibrosis by starting with a FIB4. If the FIB4 is less than 1.3, the risk is low. The negative predictive value is about 93% there, so we're fine and we're reassured by that. And then they should discuss lifestyle modifications of those risk factors from the metabolic space, and then reassess every 1 to 2 years if that high risk persists. If the FIB4 is 1.3 or higher, we call them intermediate to high risk, and we recommend stiffness measurement or assessment either with elastography, so FibroScan, MRE, or ELF if really patients do not have access to either of these two methods. The cutoff here, note, is 9.2 to align with what the field has kind of evolved over time and to exclude those potential false positives if we were to use a lower cutoff of 7.7. So if these are lower than these parameters, the patient is considered at a low risk despite a FIB4 that is borderline. We focus on lifestyle modification and we consider repeating a liver stiffness in 2 years, or an ELF again if liver stiffness is not available or accessible. If the cutoffs are above those that I mentioned here, then we recommend referral to the mast cell clinic where we take over and we either discuss more intensive treatments. We discuss medications that are FDA approved for MASH with moderate to advanced disease, where we consider clinical trials. So I mentioned at the beginning the medications that are FDA approved, and I want to bring that in the context of how we use these markers or non-invasive tests for fibrosis assessment to determine who is a candidate for these medications. Both resmetirom, which was approved in 2024, and semaglutide, that goes under the brand of Wegovy, which was approved in 2025. Both of these have the same indication, MASH with moderate to advanced fibrosis, which means stage 2 to 3. Not earlier, not later. So we have that Goldilocks kind of type of picture that we have to make use of our non-invasive test to make sure the patient fits in. These are not approved in patients with cirrhosis. Resmetirom is currently under evaluation in a clinical trial for those with cirrhosis. So until we see safety and efficacy data there, we cannot recommend it. And semaglutide doesn't have an approval for MASH cirrhosis yet. It can be used in those with cirrhosis under different indications for weight loss, for example. So AASLD came with practice guidance on how to select these patients for both resmetirom, that's the first one that came out in 2024, shortly after the FDA approval, and then we have an updated one for semaglutide, which I'll talk about later. But looking at the first one with resmetirom, you can see what the tests were recommended at that time for selection of these candidates, and those were FibroScan with a value between 8 and 15 kilopascals, and MRE with a value of 1 to 4.4 kPa, or if there is a historical biopsy available, then MASH with stage 2 to 3 fibrosis. Biopsy is not needed for the indication of the prescription, fortunately. ELF was not part of this recommendation because ELF had not been studied in that trial, the phase 3 trial for resmetirom. So you see that green box here for those parameters. The yellow box means that anything outside of this needs to be individualized by evaluation from a hepatology specialist. And we had a red box, meaning don't use in certain parameters that were highly consistent with cirrhosis, or BCT of 20 or higher, MRE of 5 pascals or higher, and some other concomitant issues that you can see listed here. The same parameters are used to assess for response to treatment at 12 months. Basically, if there were improvement in these parameters of BCT or MRE by these relative numbers seen here, there was a beneficial response, and the resmetirom would be continued. If there were worsening of nil-dot was a NIT type of then resmetirom would be stopped. That's the formal AASLD guidance. There was an expert panel recommendation that came along around in parallel to that AASLD guidance. This was published in CGH. That kind of expanded the list of NITs beyond those studied in the trial, and ELF was included in this guidance. The cutoff of 9.2, which you've seen before, comes here as well. They make a recommendation that if it's this range, a second non-invasive test should be used, but if it's above 9.8 up to 11.3, it can be used in isolation to determine candidates to therapy. If your ELF is above 11.3, then we should not use resmetirom because the patient's high likelihood of having cirrhosis. The semaglutide guidance, as I said, from AASLD came recently, just online in the last few months, shortly after the approval of Wegovy in August. And this includes ELF because ELF was studied in the ESSENCE trial of Wegovy for MASH. And we were able to use the ranges of those participants to make some recommendations for use of ELF to select candidates for treatment. In addition to the BCTE and MRE parameters, those are similar to the ones that were recommended for resmetirom treatment. But now we add the ELF based on trial data, so more supported, and we recommend a range of 9.2 to 10.5, which was about the interquartile range of those people with stage 2 to 3 fibrosis, which would have been candidates for that treatment. Anything above 10.5 up to 11.3 has to be backed up by another non-invasive test just to make sure that we are within that stage 2 to 3 fibrosis range. So a supportive type of non-invasive test in addition to ELF. And again, if it's above 11.3, the recommendation stays that this is likely cirrhosis and we should not use Wegovy for the MASH indication in those patients. We also make recommendations in response to therapy. This is at 72 weeks. This is the trial duration for Wegovy, so that's where the clinical response should also be assessed. Same cutoffs for BCTE and MRE are similar. And then for ELF, a cutoff of 0.5 decrease, so an absolute decrease of 0.5 would be consistent with a supportive or a beneficial response that would support the continuation of semaglutide. If these thresholds are not met, we would have to evaluate strategies. If more than one non-invasive test is going in the wrong direction, obviously we will stop the semaglutide due to no response. So we do have what I would say an expanded armamentarium of using these non-invasive tests in clinical practice in selection of treatment candidates and also response to therapy, which is really good for us. So I mentioned BCTE or FibroScan and MRE. I want to speak a little bit of these imaging techniques that we use also as a supportive measure for fibrosis assessment. There are three types of them. One is the transient elastography or VCTE or FibroScan. We can see kind of the depth and the length of or the volume of liver assessed with that method. We have ultrasound-based methods, so these are softwares attached to the conventional ultrasound systems that can also measure the stiffness. You can see the depth and also the volume of the liver that these assess in comparison to the FibroScan. And we have MR elastography also as an opportunity, which doesn't have, it has a larger volume of liver assessed. It's essentially 4 slices of the liver that are measured to estimate the stiffness on an elastography method like you see here. So the accuracy is higher for this method because of these technological advancements in that. A little bit about their performance. We can measure both the steatosis by the CAP measure here, and you can see the accuracy for steatosis grades 1, 2, or 3. And we can see the liver stiffness measurement here in orange for these thresholds of stage 2, 3, or 4 fibrosis. As I said, this is the one that's important currently in clinical practice. 8 kilopascal is about 0.77 for AUROC for that determination of fibrosis. For MRE, the stage 2 fibrosis or higher cutoff is 3.1, which is what you saw in the guidances that I mentioned earlier. The AUROC for that is 0.92. So again, that increased accuracy of measurement. We can also measure the fat fraction on MRE if it's done in the correct method, which is that equivalent of CAP. So I'd like to end with a couple of clinical case studies to highlight how I would see the use of ELF in clinical practice, and then we'll open for questions for the remainder of the time. So I think, as I said, the most important and the most pertinent reason for the use of ELF would be to determine the fibrosis stage for treatment, right, for Wegovy or Rezdiffra. So we have here a hypothetical case, but it's something that I see in my practice very frequently. We say a 57-year-old woman here, BMI of 32, so class 1 obesity, presence of diabetes, abnormal liver enzymes. So the classic presentation of somebody who has MASH. We calculate the FIB4 in primary care space. Let's say we get a 2.1. So it's an indeterminate. It's above that 1.3 cutoff, but not really high. But there is a signal for high risk of fibrosis or advanced fibrosis. So the question could be, should I refer this patient to hepatology? It's maybe a 3-month wait. Could this be an indeterminate FIB4, but actually the patient has a lower stage of fibrosis for which we don't need to necessarily spend the resources or patient's time to refer to hepatology? So then maybe an available next line would be to test an ELF. And in this case, it would be a value of 10, which is above that 9.2 that I mentioned before. It's well within the range of treatment candidacy with those 2 approved medications. So this would be definitely a patient that would be supportive of obtaining the VCT if available, or if not available, or is not available, send them to hepatology because this is a really nice candidate for treatment. And it's better to support it with more than a FIB4. I didn't really spend too much on FIB4, but I do want to say that it's used because of its accessibility, but it's not necessarily for performance issues to determine stage 2 fibrosis versus stage 4. There are some limitations due to age. Age is a component of this calculation, so it doesn't have a really good performance at the extreme of ages. So those younger than 35, for example, will always have a low FIB4, even if they have advanced fibrosis or even cirrhosis. So in that situation, we would benefit from another blood test such as ELF to really support that what we're thinking is advanced fibrosis is truly what it is. The other extreme of age being 65 or higher, we use a cutoff of 2, not 1.3, because a higher age will bring that score high simply due to age and not because of fibrosis. But even then, in a 70-something-year-old, that FIB4 will be high just due to age, and not necessarily because of fibrosis in the liver. So it's really helpful to consider that age limitation, which is why it would be a really good use of another non-invasive test for that situation. So that's one case. Another case would be to clarify the stage for treatment with Rezdiffra, for example. As you recall, it's not approved in those with cirrhosis. We don't know about safety in those with cirrhosis, and until we have further data, we cannot recommend it in those people. That is as simple as it may sound. It's sometimes hard to delineate in clinical practice what really is cirrhosis and what is just stage 3. Could that be a candidate? Is it too late? It's sometimes a fine line. So I'm giving you an example here that I again see commonly in my practice. 67-year-old man with several metabolic comorbidities such as diabetes, hypertension, dyslipidemia, and the new diagnosis of MASLD. FIB-4 is 2.6, so again, that borderline of high could be straight directly sent to hepatology, could be a cirrhosis diagnosis, or it could be high just because the patient is a little bit older. Maybe the AST and ALT are a little bit higher, so that drives it just simply due to inflammation plus age and not necessarily fibrosis. We do, let's pretend there's an ECT available, it's done, there's a liver stiffness measurement of 18. Remember that treatment range was 10 to 15, where we can safely say it's stage 2 to 3, not cirrhosis, we can go ahead and treat or refer to hepatology for treatment. But this patient's 18, so 15 to 20 needs further evaluation because they could have cirrhosis in this range. So we look into other things. This data alone is not sufficient to exclude somebody or make them a treatment candidate for Rezdiffra, or even Wegovy if we want to go with the MASH indication for the prescription. So we need more. What else is there? So we have ELF as an opportunity, or we have MRE. So again, depends on what the health system has available. It's good to know that in this situation, something else is needed. And if, let's say, we use an ELF and we get a value of 11.6, which is higher than 11.3 that I mentioned before, it's highly suggestive of cirrhosis, then the treatment is basically not a consideration at this stage or at this point, because we have now a few non-invasive tests that line up towards that more advanced spectrum of the disease, so it may not be the safest. If the ELF would be below this 11.3 in conjunction with an LSM that sits in this gray zone of caution, but it's less than 11.3, there's no MRE available, we don't really have anything else, that would be a useful additional marker to say, yeah, we have more supportive evidence that the patient is more towards stage 3 and away from cirrhosis, so we could consider treatment eligibility for Rezdiffra. So it's part of that puzzle that is a really good and useful piece to kind of put things together, especially when this gray zone is a little bit of a conundrum in clinical practice, and especially when now we have that go, no-go decision to treat or not to treat. Whereas before we had lifestyle changes, lose weight didn't really make a difference where you were situated. Now it makes a big difference. As we move forward into the space of FDA-approved drugs for cirrhosis, we're not there yet. It'll be another maybe 3-4 years until we're there. That will probably also be pertinent. If we have drugs approved for cirrhosis, but not for stage 2 to 3, again, this will be even more important to see which drug candidate is this patient a good option for. Right now, for a patient like this, like I'm doing here with somebody who would not be a candidate for Rezdiffra, not a candidate for the FDA-approved indication for Wegovy. If we want to do something liver-directed, it would be a candidate for clinical trials, basically, for cirrhosis states. So I think this ends my conclusion, my presentation. I think I will follow with these key takeaways that AASLD guidelines and AGA and ACG and EASL guidelines all recommend non-invasive tests as standard of care. They all currently start with FIB-4 until we have better accessible non-invasive tests in the primary care space. ELF is recommended as secondary non-invasive test in the AASLD guidelines, and there are actionable cutoffs. And as I mentioned, they may change over time as we learn more about these cutoffs to really balance the sensitivity and some specificity, and make sure that we funnel the right patients to the liver clinics to not overburden them with early disease, but also send the right patients at the right time. So ELF can be used to determine further need for elastography or as an additional non-invasive test when two others are discordant, as I mentioned before. And lastly, as of August 2025, we have the second drug in addition to resmetirom, which is Wegovy, was the only approved MASH therapy for non-cirrhotic MASH with stage 2 to 3 fibrosis. And the label does not require biopsy, so the use of non-invasive tests became practically pertinent.